Hey everyone, and welcome to our deep dive. Today we're going to be taking on the 2024 European Association of Urology guidelines for urological infections.
It's a really comprehensive document.
Oh, absolutely. It covers the gamut.
Yeah.
Everything from common infections to some things you might not have even heard of.
Exactly. And what's really striking about these guidelines is the emphasis on really understanding the different types of UTIs.
Okay, so right off the bat, we're not talking about a one-size-fits-all approach.
No, definitely not.
Like you can't just say, oh, UTI, take this pill.
It's more nuanced than that, right? It's like trying to figure out if you have a cold or the flu or pneumonia, you wouldn't treat those the same way.
And just to be clear for our listeners, when we say UTI, we're talking about urinary tract infections.
Exactly.
All right, so how do we start to break down this world of UTIs?
Well, a major distinction right from the get-go is between uncomplicated and complicated UTIs.
Okay, so uncomplicated versus complicated.
Yeah, uncomplicated UTIs are usually pretty straightforward to manage, whereas complicated UTIs, well, they involve underlying issues that can make them a lot trickier to treat.
Got it. So it's not just about the infection itself. It's about what else might be going on in the body
Exactly.
that's making it harder to fight off.
Yeah, think of it like a leaky faucet.
Okay.
You know, you can keep mopping up the water, but if you don't fix the source of the leak, it's just going to keep happening.
So we got to find the root of the problem.
Precisely.
Yeah.
And this is where antimicrobial resistance comes in.
Okay, right. So this is a big concern, especially with, the overuse of antibiotics and bacteria becoming resistant to treatment.
Exactly, and that's why these guidelines are all about promoting appropriate antibiotic use, what we call antimicrobial stewardship.
Being smart about how we use antibiotics.
Yes, because we don't want to end up in a situation where the antibiotics we have are no longer effective.
Right. We need them to work when we need them.
Absolutely.
Now, here's a question that I've always wondered about. Do we always need to treat bacteria in the urinary tract, even if there are no symptoms?
Ah, you're talking about asymptomatic bacteria or ABU?
Okay, ABU, asymptomatic bacteria. So that's basically you've got bacteria hanging out, but it's not causing any trouble.
Exactly. It's like having house guests that, they're there, but they're not bothering you.
So we can just let them be.
In most cases, yes. Treating ABU when it's not causing any symptoms can actually do more harm than good.
Interesting. So it's not always about wiping out every single bacteria.
Right. It's about finding that balance.
But I imagine there are exceptions to this rule, right? Like, what if someone's pregnant or about to have surgery?
You're right. There are definitely situations where treating ADU is important. Pregnancy is one.
Okay.
Because the bacteria could potentially harm the developing baby.
Makes sense.
And before certain urological procedures, it's important to clear any bacteria that could cause problems during or after surgery.
So again, it's not a one-size-fits-all approach. It's about weighing the risks and benefits for each individual case.
Exactly. Personalized care is key.
Now, let's talk about something that I think a lot of our listeners can relate to, uncomplicated cystitis.
Oh, yes, the classic UTI.
Yeah, that burning sensation when you pee, the constant urge to go. Not fun.
Not fun at all. But the good news is, diagnosing uncomplicated cystitis is usually pretty straightforward. Often doctors can make a diagnosis based on your symptoms alone.
Okay, so no need to rush to the lab for a urine test right away.
Often not. And here's something that might surprise you. Antibiotics aren't always the first line of defense for uncomplicated cystitis.
Wait, really? I thought antibiotics were like the go-to treatment for UTIs.
They often are, but sometimes good old-fashioned pain relief like ibuprofen can be enough to manage the symptoms until the infection clears on its own.
Wow, I had no idea.
It's all about finding the most effective treatment for each individual case.
And sometimes less is more.
Exactly. Of course, if antibiotics are needed, the guidelines offer recommendations on the best options, taking into account the specific type of bacteria and local resistance patterns.
Okay, so we're being very mindful of antibiotic resistance here.
Always.
Now, what about those of us who seem to get UTIs over and over again, recurrent UTIs?
Ah, yes, the dreaded recurrent UTI.
Yeah. It can be so frustrating and really impact someone's quality of life.
Absolutely. And there are a lot of different factors that can contribute to recurrent UTIs.
No, okay, so what are some of the things that might make someone more susceptible?
Well, it varies by age group. For premenopausal women, sexual activity is a big one.
Okay.
And for postmenopausal women, it's often related to changes in the vaginal flora.
Makes sense. So what can we do to break this cycle of recurrent UTIs?
Well, the good news is there are several strategies. Lifestyle changes are a great starting point.
Okay, like what kind of lifestyle changes?
Think staying hydrated, practicing good bathroom hygiene, peeing after intercourse.
Good reminders.
And then for postmenopausal women, Vaginal estrogen replacement can be helpful.
Okay.
And then there are things like immunoactive prophylaxis and even probiotics, which are becoming increasingly popular.
So there are options beyond just antibiotics.
Absolutely. Antimicrobial prophylaxis, which is basically taking antibiotics regularly to prevent infections, is an option.
Okay.
But it's usually a last resort when other measures fail.
Right, because we want to be mindful of those potential side effects and avoid overuse of antibiotics.
Exactly.
Now let's talk about a more serious condition, pyelonephritis.
Okay, so we're moving up the urinary tract now.
Exactly.
Yeah.
This isn't just a bladder infection. This actually affects the kidneys.
That's right. Pyelonephritis is an infection of the kidneys, and it can be much more serious than a simple UTI.
And how do we differentiate between the two?
Well, one key distinction is whether it's obstructive pyelonephritis, meaning there's a blockage in the urinary tract.
Okay, so the urine can't flow properly.
Exactly. And this can lead to a buildup of pressure and even urosepsis, which is a life-threatening condition.
Okay, so we definitely want to catch this early.
Absolutely. Early diagnosis and treatment are crucial.
So what does that look like? How do we diagnose pyelonephritis?
The guidelines recommend urinalysis, urine culture, and sometimes imaging tests like ultrasounds or MRIs to check for any blockages or stones.
And treatment.
It involves antimicrobials, but the choice of antibiotic and the route of administration, whether it's oral or intravenous, depends on the severity of the infection.
Okay, so again, it's not a one-size-fits-all approach.
No, it's all about tailoring the treatment to the individual patient.
Now, speaking of complexities, let's delve into the world of complicated UTIs, or CUTIs.
All right, so these are the UTIs with those underlying issues we talked about earlier.
Exactly, the ones that make them harder to manage.
Right. Think of it like this: with a simple UTI, you're just dealing with the infection itself.
Okay.
But with a CUTI, you've got that infection plus other factors that might be contributing to it and making it harder to treat. It's like trying to put out a fire while someone's constantly adding more fuel to it.
I like that analogy.
Wow.
So what are some examples of those underlying issues?
It could be anatomical abnormalities in the urinary tract, things like kidney stones or an enlarged prostate. It could also be health conditions like diabetes or a weakened immune system.
Got it. And then there's the added challenge of multi-drug resistant uropathogens.
Oh, yes. These are bacteria that have become resistant to multiple types of antibiotics.
So they're like the supervillains of the bacteria world.
In a way, yes. And that's why these guidelines rely heavily on the SWAB guidelines, which are developed by experts in antibiotic policy.
Okay, so these are guidelines specifically for choosing the right antibiotics.
Exactly. They focus on choosing the right antibiotic for each individual case based on the severity of the infection, local resistance patterns, and the patient's specific characteristics.
So it's even more important to get it right the first time around.
Absolutely. And here's another crucial point. Managing that underlying urological abnormality is just as important as the antibiotic treatment itself.
We got to fix that leaky faucet.
Exactly. You need to address both for long-term success.
Now let's move on to a type of UTI that's unfortunately quite common, especially in healthcare settings. Catheter-associated UTIs, or CAUTIs.
Right. These are infections that develop in people who have a urinary catheter in place.
And they can be a major source of complications.
They can. The guidelines highlight that the duration of catheterization is a major risk factor.
So the longer the catheter is in, the higher the risk of infection.
Exactly.
Yeah.
So minimizing catheter use whenever possible is key.
Okay, so if you don't need it, don't use it.
Exactly. And the guidelines also address the challenge of distinguishing between CAABU, remember that's asymptomatic bacteria in the context of a catheter,
Right.
and a true CAUTI.
So not all bacteria in the urine need to be treated.
Exactly. So instead of just relying on cloudy or odorous urine, the guidelines recommend a more comprehensive approach to diagnosis.
Makes sense. So how can we prevent CAUTIs?
A big one is using catheters only when absolutely necessary and removing them as soon as possible.
Okay.
And when catheters are needed, there are things like using hydrophilic-coated catheters, which are designed to reduce the risk of infection.
And avoiding unnecessary prophylactic antibiotics.
Exactly.
Right. It's all about using antibiotics judiciously.
Absolutely. Now, on a more serious note, let's talk about urosepsis, which is a potentially life-threatening complication of UTIs.
Right. This is when the infection spreads to the bloodstream and the body's response goes into overdrive.
Exactly. It's a very serious condition that requires prompt recognition and treatment.
So time is of the essence.
Absolutely. The guidelines provide tools like the SOFA and QS-SOFA scores to help clinicians identify urosepsis quickly.
Okay, so early detection is key.
It is. And treatment involves timely antimicrobial therapy, often given intravenously,
Okay.
as well as supportive care to stabilize the patient's vital signs and address any organ dysfunction.
This sounds like a really complex situation requiring a team effort.
It does. Urologists, infectious disease specialists, critical care teams, everyone needs to be on board.
Okay, so we're talking about a coordinated approach to care.
Absolutely. Now let's shift gears a bit and talk about urethritis.
Urethritis, so that's inflammation of the urethra, the
Mm.
tube that carries urine from the bladder to the outside.
That's right. And while many people associate urethritis with sexually transmitted infections, it's important to remember that it can also be caused by non-infectious factors.
Oh, interesting. So what else could cause it?
It could be things like irritation from certain soaps or detergents,
Okay.
trauma to the urethra, or even certain medications.
Got it. So it's not always an STI?
Not always. And within the realm of infectious urethritis, there's a key distinction between gonococcal urethritis and non-gonococcal urethritis.
Gonococcal versus non-gonococcal?
Yes, gonococcal urethritis is caused by the bacteria Neisseria gonorrhea, which causes gonorrhea.
Okay.
And non-gonococcal urethritis, or NGU, is a bit of a catch-all term for urethritis caused by other infectious agents.
So things like chlamydia?
Chlamydia, mycoplasma, genitalium, trichomonas vaginalis.
Okay, so a whole bunch of different bugs.
Exactly. And the key here is to determine whether gonorrhea is a likely cause, as this will guide treatment decisions.
Okay, so how do we figure that out?
Well, the first step is a detailed history and physical exam. And then the guidelines recommend using nucleic acid amplification tests, or NATs.
NADITs.
Yes, these are very sensitive tests that can detect the DNA or RNA of those infectious agents.
So they can tell us exactly what we're dealing with.
Precisely. And once you know the cause, treatment can be tailored accordingly.
And of course, we want to emphasize the importance of treating all at-risk sexual partners.
Absolutely. It's crucial to prevent reinfection and further spread.
All right, let's move on to bacterial prostatitis, which is inflammation of the prostate gland.
Okay, so now we're focusing on men's health.
Right, bacterial prostatitis is something that can really impact a man's quality of life.
It can. And it's more common than many people realize.
So how do you know if you have bacterial prostatitis? What are the symptoms?
It can vary depending on whether it's acute or chronic.
Okay, so acute versus chronic.
Yeah, acute bacterial prostatitis usually comes on suddenly with symptoms like fever, chills, pain in the lower back and genital area, and difficulty urinating.
So that sounds pretty miserable.
It can be. And then chronic bacterial prostatitis is more insidious.
Insidious.
Yes, the
Yeah.
symptoms come and go over time. It might cause recurrent UTIs, pain during ejaculation, and a feeling of incomplete bladder emptying.
Okay, so those symptoms can be a lot more subtle.
They can.
Okay.
So how do we diagnose bacterial prostatitis? Well, a key part is ruling out other conditions that can cause similar symptoms.
Okay.
And then for chronic bacterial prostatitis, the guidelines recommend the Mears and Stamey test, which helps differentiate between prostatitis and other conditions.
Got it. And treatment?
Treatment depends on the type of bacterial prostatitis. Acute bacterial prostatitis typically requires a course of high-dose antibiotics,
Okay.
while chronic bacterial prostatitis often necessitates longer-term antibiotic therapy.
So again, tailoring the treatment to the specific situation.
Exactly. Now let's move on to a condition that sounds incredibly painful: acute infective epididymitis.
Acute infective epididymitis, that's a mouthful.
It is, and it can be quite painful. It's an inflammation of the epididymis, which is the coiled tube that sits on top of each testicle.
Okay, so this is definitely in the sensitive area.
It is, and it's usually caused by bacteria that migrate from the urethra or bladder.
Okay.
Common culprits include Enterobacterales, Chlamydia trachomatis, and Neisseria gonorrhea.
So some familiar names.
Exactly. But the key here is to determine whether gonorrhea is a likely cause,
And why is that important?
because it will guide treatment decisions.
So treatment will involve antibiotics, but the specific types will depend on the bacteria involved.
Precisely. And in severe cases, intravenous antibiotics might be necessary.
Okay, got it. Now let's talk about a rarer but potentially very serious condition, Fournier's gangrene.
All right, so now we're getting to the really serious stuff,
This is a rapidly progressing soft tissue infection that can be life-threatening.
right? You're absolutely right. It's a surgical emergency that requires prompt recognition and aggressive treatment.
Okay, so what should we be looking for? What are the red flags?
Painful swelling in the scrotum or perineum is a major warning sign.
Okay.
And imaging, like a CT scan or MRI, is crucial to determine the extent of the infection. Treatment involves immediate broad-spectrum antibiotics, meaning antibiotics that target a wide range of bacteria, and surgical debridement, which is the removal of infected tissue.
Wow, so this is a really aggressive approach.
It has to be. Early diagnosis and aggressive treatment are key to improving outcomes in Fournier's gangrene.
Okay, so we're talking about a life-saving intervention here.
Absolutely. Now, shifting gears a bit, let's talk about HPV in men.
HPV, or human papillomavirus, is often associated with cervical cancer in women, but men can also be affected.
Exactly. There are over 200 different types of HPV, and while some are harmless, others can cause health problems in both men and women.
So men aren't just carriers, they can actually develop health issues related to HPV themselves.
That's right. In men, HPV can cause genital warts, which are small, fleshy growths in the genital area.
Okay.
And certain high-risk types of HPV can increase the risk of cancers of the penis, anus, and throat.
So it's not just a cosmetic issue.
No, definitely not. So what are the recommendations for diagnosis and management? Well, a thorough physical examination is essential. And for some men, an acetic acid test might be used to help visualize subclinical lesions.
Okay.
Treatment options depend on the type and severity of the lesions, ranging from topical medications to surgical removal.
And I imagine patient education is a big part of this as well.
It is. Talking about HPV transmission, safe sex practices, and the importance of self-monitoring for new lesions.
Empowering patients with knowledge.
Exactly. Now let's move on to a condition that's often overlooked, genitourinary tuberculosis, or GUTB.
GUTB.
Yes, it's a form of tuberculosis that affects the urinary and reproductive organs.
So not just the lungs.
Right. While TB is most commonly associated with the lungs, it can actually spread to other parts of the body, including the kidneys, bladder, prostate, and testicles.
And how common is GUTB?
It's more prevalent in certain parts of the world, but it's often underestimated in non-endemic regions like Europe.
Okay, and why is that?
Part of the reason is that it can mimic other urological conditions, making diagnosis tricky.
So it can fly under the radar.
It can, so what are we looking for? What are the signs and symptoms of GUTB? Well, it can vary depending on the organs involved.
Okay.
Some people might experience frequent urination pain during urination, blood in the urine, or pain in the lower abdomen or back.
So it can really mimic other common urological problems.
Exactly. That's why a high index of suspicion is important, especially in individuals who have risk factors for TB, such as a history of TB infection, a weakened immune system, or travel to areas where TB is prevalent.
So we need to be thinking about it.
Yes. And how is GUTB diagnosed? Unfortunately, there's no single test that can definitively diagnose GUTB.
Okay.
It often requires a combination of tests, including urine tests, blood tests, imaging studies, and sometimes even a biopsy.
So it can be a bit of a diagnostic puzzle.
It can be, but the good news is that GUTB is treatable with antibiotics.
That's good to hear.
It's a long course of treatment, usually lasting at least 6 months, and it often involves taking multiple medications.
Okay.
Early diagnosis and treatment are key to preventing serious complications like kidney damage.
So again, early detection is critical.
Absolutely. Now I see we're wrapping up this section with a discussion of antibiotic prophylaxis.
Antibiotic prophylaxis. So this is the practice of giving antibiotics before certain procedures to prevent infection.
That's right.
So like before a cystoscopy or a prostate biopsy.
Exactly. The guidelines outline specific recommendations for antibiotic prophylaxis in various urological procedures, taking into account the type of procedure, the patient's risk factors for infection, and local resistance patterns.
So again, it's not a one-size-fits-all approach.
Definitely not. The decision to use antibiotic prophylaxis should always be made on a case-by-case basis, weighing the potential benefits against the risks.
And of course, it's important to remember that antibiotic prophylaxis is just one part of a larger strategy to prevent infections.
Absolutely. Things like maintaining sterile technique during procedures and proper hand hygiene are also essential.
Right, it's a multifaceted approach.
It is.
Wow, this has been an incredibly comprehensive overview of urological infections. I'm already feeling so much more informed.
It's a complex topic, but I think we've laid a solid foundation for understanding the key issues.
And I think we've really highlighted the importance of individualized care, recognizing that each patient's situation is unique and requires a tailored approach.
Exactly.
We're just getting started, though.
Oh, yes. There's so much more to explore in these guidelines.
So be sure to join us for part 2 of our deep dive, where we'll delve into even more specific recommendations and insights. Welcome back to our deep dive. I'm still trying to absorb all that info about the different types of UTIs.
It's a lot to take in, for sure, but I think we made some good progress.
Yeah, we did. And before we move on, can we circle back to antibiotic prophylaxis for a minute?
Sure. What would you like to clarify?
I'm still a bit fuzzy on when it's actually recommended for which procedures?
Of course, happy to break it down further.
Yeah.
So let's start with urodynamics, where they're basically checking how your bladder's working.
Okay, yeah, for urodynamics.
The guidelines generally don't recommend routine antibiotic prophylaxis for those.
Interesting. What about cystoscopy, where they use a scope to look inside the bladder?
For cystoscopy, it's a similar story. Prophylaxis isn't routinely recommended unless there are some specific risk factors present.
Okay, so again, it's all about individualized assessment, weighing those risks and benefits.
Precisely. Now, when we talk about procedures for kidney stones, well, the recommendations can change a bit depending on what kind of procedure it is.
So, for example, like if someone's having extracorporeal shockwave lithotripsy to break up the stones.
Right. For ESWL, prophylaxis isn't usually needed.
But for something like ureteroscopy or percutaneous nephrolithotomy, where they're actually going in and removing the stones.
Yeah, in those cases, the guidelines do suggest considering trimethoprim or trimethoprim sulfamethoxazole for prophylaxis.
Got it. So different stone, different approach.
It can be like that.
Yeah.
All right, moving on to procedures involving the prostate. What about terpre transurethral resection of the prostate?
Okay, for therapy.
Typically, a second or third generation cephalosporin is recommended for prophylaxis.
Okay, so a different class of antibiotics there. And what about transurethral resection of the bladder, TURBT?
For TURBT, it's a little more nuanced. The guidelines actually suggest individualizing prophylaxis based on the patient's risk of developing sepsis after the procedure.
So taking into account their overall health and if they have any other conditions that might make them more susceptible.
Exactly. Now let's talk prostate biopsy. This one seems to have a lot of different options for prophylaxis.
Yeah, it does. It can be a bit overwhelming trying to sort through all of them.
Well, the guidelines discuss a few different approaches. They talk about targeted prophylaxis based on what a rectal swab or a stool culture shows.
Okay.
And there's augmented prophylaxis, where they might use multiple antibiotics. And they even discuss using alternative antibiotics like fosfomycin.
Wow, so many choices. It seems like the decision really depends on a whole bunch of different factors.
It does. Local resistance patterns, the patient's allergy history, their individual risk factors, all those things come into play.
All right, I think I'm starting to get a better handle on antibiotic prophylaxis now. It's definitely more complex than I realized at first.
For sure. But remember, the big picture here is informed decision-making. Using antibiotics wisely and only when they're truly needed.
Right, striking that balance between preventing infections, but also avoiding the overuse of antibiotics, which can lead to resistance.
Exactly. Now, I'm curious about the role of imaging in diagnosing these infections. We've talked about it a bit already, but can we dive a little deeper?
Yeah, I'd love to hear more about how imaging helps clinicians figure out what's going on.
Imaging is essential. It lets clinicians actually see what's happening in the urinary tract and spot any abnormalities that could be causing or contributing to an infection.
So it's like having a window into the body.
Exactly. So what are some of the common imaging techniques?
Well, ultrasound is often the first-line imaging modality.
Okay, ultrasound.
Yeah, it's non-invasive, relatively inexpensive, and pretty widely available.
And it can show things like kidney stones, blockages in the urinary tract, or abscesses. All of that ultrasound gives us valuable information about the structure of the kidneys, the bladder, the ureters.
Okay, what about CT scans? When are those used?
CT scans are helpful when you need more detailed anatomical information. They provide these cross-sectional images of the body and can detect those subtle abnormalities that might be missed on an ultrasound.
So they provide a more in-depth look.
Exactly.
Yeah.
And then there's MRI, which might be preferred in some cases.
When would you use MRI?
Well, particularly for pregnant women, as MRI avoids radiation exposure.
Makes sense.
And it's also very good at visualizing soft tissues, so it can be helpful in certain situations where a CT scan might not give you all the details you need.
Okay, so the choice of imaging really depends on the specific situation and what the clinician is looking for.
Precisely. Each imaging modality has its strength and its limitations, so the clinician will choose the one that's most likely to give them the information they need to make the right diagnosis and guide treatment decisions.
This has been another incredibly informative session. I feel like we've really gotten into the nitty-gritty of diagnosing and managing urological infections.
It's been a deep dive, for sure.
But we're not quite done yet.
Not quite. There are still a few more nuggets of wisdom I want to share from these guidelines.
Oh, I'm ready for more. Bring it on.
Well, then be sure to join us for part 3, where we'll wrap up our exploration with some final insights and practical takeaways.
Welcome back to our final part of this deep dive. Going through all this, I'm struck by how much emphasis these guidelines put on individualized patient care.
Absolutely. It's a really important theme. throughout the document.
Yeah, it's like we've been saying, cookie-cutter approaches are just not going to cut it when it comes to urological infections.
Right. Every patient is different. Their medical history, their risk factors, even their personal preferences, all of these things need to be considered.
So the guidelines are more like a framework than a strict set of rules.
Exactly. It's up to the clinician to use their judgment and expertise to apply those recommendations to each individual patient.
It's like tailoring a suit. You got to make sure it fits perfectly.
That's a great analogy. And speaking of tailoring treatment, another key aspect is shared decision-making.
So it's a collaborative process between the doctor and the patient.
Exactly. It's not just the doctor dictating what's going to happen. It's about open communication, explaining those different treatment options, the potential benefits and risks.
Right, so the patient really understands what's involved.
Exactly. And then working together to come up with the best course of action.
I love that. It gives patients a voice and makes them feel like they're part of the team.
That's the goal. Informed patients are more likely to be engaged in their care and make decisions that they feel good about.
Now, before we wrap up, I think it's worth emphasizing the whole issue of antimicrobial stewardship again.
It's so important, especially with antibiotic resistance being such a major threat.
It's scary to think that those life-saving medications might not work when we need them.
Exactly. So we all have to do our part to use antibiotics responsibly.
And that means, what? Using them only when they're truly necessary.
Exactly. And choosing the right antibiotic for the specific infection and making sure patients understand the importance of completing the full course of treatment.
Even if they start feeling better before they finished all the pills.
Yes, that's crucial. It helps ensure that the infection is completely gone and prevents those bacteria from developing resistance.
Right. We don't want to give them a chance to outsmart us.
Exactly. Now, before we say goodbye, I want to leave our listeners with a final thought.
Okay, what's your parting wisdom?
Knowledge is power. The more you know about your health, the better equipped you are to advocate for yourself and make informed decisions.
So don't be afraid to ask your doctor questions. Do your research and be an active participant in your healthcare journey.
Couldn't have said it better myself. And if you're interested in diving even deeper into these guidelines, you can find the full text online.
We'll include a link in the show notes for everyone.
It's a bit dense, but it's a great resource if you really want to geek out on the details.
Well, on that note, I think it's time to wrap up this episode. Thanks for joining us on this incredible journey through the world of urological infections.
It's been my pleasure.
And to all our listeners out there, remember, knowledge is power when it comes to your health. Stay informed, stay proactive, and don't hesitate to reach out to your healthcare provider if you have any concerns.
Until next time, stay healthy.